I used the word quotidian. This is a quotidian ethic. And if you could remember that, I'd be very, very happy. So this evening, I was assigned the task of talking about moral distress. And so I'm going to go through some definitions and discussion about moral distress, and then we'll turn it over to Bridget and later to Jane. I'm glad the lights are dim because my wife says I look better in the dark. So one of the things I wanted to do to start off with is just kind of do my ethics primer. I am a bioethicist, so I want to take advantage of the time that I have. And the first thing that I want to bring to our attention is, what are the essential questions of bioethics? And I have this wonderful child who goes with me everywhere that I go, and she never grows old. And I think if she's asking this question when she's at this age, what is she going to ask when she gets to university? So the first question of bioethics, from my perspective, is, what is the good that you want to achieve? All of our work in healthcare, or whether we're caregivers looking after somebody who's vulnerable, we want to make a difference. We want to do good. I was presenting in another place and somebody was challenging me on that notion of good. Right? I thought, how wonderful it is if we could have an argument about what is doing good, as opposed to some of the many other things that we could argue about. The other question of bioethics, and this is the one that I like, and if you could hold on to this thought too, is this question of what could we do versus what should we do? There are a lot of things we could do, but should we? I remember doing a presentation, and there was a staff member who was a nurse from a long-term care facility, and she talked about there was a resident who was biting other residents, and said, we could pull out his teeth, but should we? And I said, how do I respond to that as a bioethicist? Because I've never heard that one before. And he didn't have dentures, by the way, so it wasn't gumming. And so how can we find a less intrusive way of dealing with this issue of this gentleman biting other residents? So could versus should. Now, answering the issue of what could we do versus what should we do is a little bit more complicated. In fact, a lot more complicated. And one of the reasons why I love my job as a bioethicist is I have the opportunity to go between medicine. So what is the diagnosis we're dealing with? What is the prognosis we're dealing with? What is the quality of life we're dealing with? All these parts, the physical part of a person's life we're taking into consideration. And as Jane will speak later about the legal side, in bioethics there's a very strong intersection of law and ethics. Whether it's the Healthcare Consent Act, the Mental Health Act, Health Promotions and Protections Act, and numerous other acts that govern what we do in healthcare. Certainly, philosophy is a big part of bioethics, a big part of our foundation. Our notions around what is the dignity of a human being, what is the notion of person, and also, our debate about autonomy and the value around that issue, and the greater good is certainly very much steeped in the foundations of philosophy. However, I will tell you that nobody ever asked me what a philosopher would say or do at a critical moment in time. What they would ask me is, what does my faith, what does my culture teach me, or ask me that I should do? And when we're working on answering the should question, we try to put all those together to come to a resolution of that most difficult question. Now, most of us who have been in healthcare, we are familiar with these values. These are values of autonomy, the respect for the individual, beneficence, doing good, and avoiding harm. And in the context of bioethics, justice I like to think more of in the sense of fairness. Sometimes when you're allocating limited resources, what's the fair way to allocate those limited resources? I'm very conscious, about the notion of autonomy, because in many cultures there may be a different view of autonomy, and we have to take that into consideration. And those of you who work in healthcare in any way know there are situations where somebody may say to you, don't tell mom, don't tell dad about their diagnosis. Well, that may very well be a part of their culture, part of their tradition. But how do we work against that or with that when you have to get consent for a treatment? Now, I want to bring to your attention, I put up there the familiar principles that you would know, but I want to indicate some other principles or virtues that I think are important. And as we're talking about the whole notions of transitions in care planning over the next little while, and as you're sitting at your table, do think about, one, the principles we just spoke about, but also these virtues: caring, compassion, courage, empathy, working together, justice. Think about those virtues. What about the virtues of integrity, truthfulness? And I was interested in this one. I was doing a little bit of reading. Righteous indignation. You know, sometimes there's a place in our role to say, something's not right here. It takes some courage to do that, though, because as I've learned in some cases, there are career-limiting moves. And you have to be cautious about when do you speak. I think, Phoebe, sorry, or somebody was telling me earlier, there's language that's used around you're stepping on a landmine in these issues. So these are very important. Now, this is a quote that I borrowed from Phoebe. Values underline our choices and actions as individuals and healthcare providers. They are deep-seated beliefs influenced by our personal convictions and experiences. And this comes from thinking around value-based decision-making. In much of our work, we think about evidence-based decision-making. But I have seen and heard and read about how sometimes we make decisions based upon our values, and then we look for the evidence to support the decision that we've made. So this is very important to keep in mind. So principles, virtues, and values. And as we go further on and we think about the notion of moral distress, those collide, and that's what causes us, collide with some of the values around utilization and the challenges there. That's what causes us some of the moral distress. Now what I'm going to do for just a few moments is I'm going to ask Phoebe to come up and share a story. Now, I'm very proud of Phoebe, and there's a number of other people who have taken my work to another level. I mean, I've opened the door to the subject of transitions in care planning, but Phoebe and others have made it part of their study in school. And Phoebe just finished the Masters of Health Science and Bioethics at the University of Toronto's Joint Centre for Bioethics. And I had the privilege of listening to one of her presentations on this subject, as well as reading this wonderful paper that she's completed. So it gave me a good foundation. So it is my pleasure to introduce to you Phoebe.
Thank you, Bob. That's very kind of you. So my paper was interviews with various healthcare professionals from the community and the hospital. And I formed a case from my personal experience as a healthcare worker and also my interviews with community and hospital workers. So you may recognize aspects of this case in your own work. So Joe, an 85-year-old with dementia, has just been admitted to hospital for the 4th time in a few months with failure to thrive and caregiver burnout. Those may be familiar terms to some of you. He is typically sent home with additional CCAC Homefirst hours and returns after the hours have been automatically reduced. He lives at home with his frail elderly wife named Anna. His daughter lives nearby but works full-time and has a child with special needs. Joe needs assistance with most activities of daily living and is incontinent. He wanders and has limited short-term memory. CCAC employees often leave due to safety concerns from Joe's aggressive tendencies. Convalescence is no longer an option as he hit a staff member. He feels his family feels the support is not enough and cannot pay for additional services. Anna would like to keep Joe at home as per his wishes, but thinks long-term care is now needed. He's now in an acute unit. There are 24 patients waiting in the AR. The manager and the physician are receiving pressure to discharge Joe. The hospital team feels distressed that Joe, a frequent flyer, I'm sure you may hear that term also, may go back home despite repeated readmissions, family strain, and a suspected unsafe environment. The CCC coordinator was instructed not to discuss long-term care as an option by her manager. Furthermore, the capacity assessment supported Joe's ability to make decisions about his living environment despite some memory issues. Joe was sent home again with maximum CCC supports possible. The team feels the coordinator pushed Joe home by not mentioning long-term care and therefore did not obtain an informed decision. The team also expressed concerns that the coordinator did not do a proper capacity evaluation for admission to long-term care as the finding opposed their impressions. They suspect it is biased. The coordinator feels the team is trying to force Joe into long-term care against his wishes due to their own biases and fears. The coordinator also feels her capacity evaluation was valid and suspects the team often skews theirs due to safety concerns.
Thank you, Phoebe. So, perhaps a question for you guys. This story sounds familiar, doesn't it? We've all encountered this story in some way. You know, whether we're a family member who maybe the discharge is being pushed a little bit prematurely, whether we're CCAC, as Frank and colleagues and other friends are, who are receiving patients from the hospital who might be having very difficult times in managing at home, or certainly as staff in the hospital who are challenged by what's the right thing to do. So you see, did you feel any sense of anger when maybe you heard the story? Or perhaps frustration? Or we've heard that story before. One of the things that I always feel challenged by is the language we use. Sometimes I'm troubled by that word, or words, frequent flyer. Helpless is also another situation, because we know that we could do better. We feel we could do better. And especially when we think about the family members, because we're concerned not only about Joe, but Joe has a spouse who's troubled by, maybe Joe is getting more aggressive and assertive at home in ways which are not safe for her. And are we being fair in terms of what we're doing to him or with him? And certainly, our values are being challenged. How do we know when we are experiencing moral distress? It doesn't take a lot of literature, and doesn't take a lot of review of, fine documents to define and to know when we're feeling moral distress. Sometimes moral distress is just that unfortunate and uncomfortable feeling that we have in our gut. By the way, I would say to you, that's also one of the ways you can identify an ethical dilemma, when things just don't feel right in your gut. And because usually that's saying to you, something's not fair, something's not right. And so when our gut is telling us something's not right, we may very well be feeling moral distress. And moral distress has different definitions. Some of it can be defined as moral uncertainty. You're unsure of what the principles or values that you should apply to a particular problem. And of course, moral dilemma is easier. There may be more than one right way to go. Yes, sending the person home is right, but we could also put them in long-term care. That's good too. Which one is right here? So that's a sense of dilemma. The other one is this: you know the ethically appropriate action to take, but you're unable to act upon it. You act in a manner contrary to your personal and professional values, which undermines your integrity and authenticity. I must say, I have to give a lot of credit to the American Association of Critical Care Nurses, because they've done some good writing and thinking about this whole issue of moral distress. There are others who have written about this, and more recently some social workers, but the Critical Care Nurses Association has been very good. A similar definition is this one. Moral distress is when persons believe they know the ethically appropriate course of action, but cannot carry out the action because of institutionalized obstacles, or when there is incoherence between what one sincerely believes to be right and what one actually does and what eventually transpires. I hope none of us are in that experience, but I'm sure we are. This, to me, is also a very big part and challenging part of our dealing with transitions in care planning. If you're wanting to uphold your values, uphold virtues, uphold principles, certainly try your best to uphold the law, and can't for some reason, or you feel challenged, certainly your integrity is challenged. It takes a lot to kind of try to reintegrate your integrity back into your life and into your work. I have also experienced from my own work, when people are experiencing moral distress, their confidence in their work and ability is sometimes challenged. Unfortunately, she can't be here tonight. It was one of my occupational therapy colleagues. She spoke of this before, how she started to question her judgment. What's wrong with my judgment about this patient? Certainly cynicism. If we have our institutional values, which are on the walls of most institutions, and they say things like compassion, trust, respect, and yet if we're not able to live that, we can become cynical. Taking all together and bringing it together, we can experience also compassion fatigue. Don't ever want you to experience compassion fatigue if I can have anything to do about it. Burnout, depression, and certainly lastly, the literature speaks to exit from the profession. We've had a number of, say nurses who get weary and tired of the fight and the battle and say, I can't do this anymore, and yet we know we need nurses. This is the one that kind of troubles me a little bit, is it speaks of the outcomes of moral distress in another way, perhaps a little bit better than I could ever do it. It causes us to deny our emotional feelings. I mean, if we heard Joe's story and we just thought, so what? That's the usual. Then there's something wrong there. I would like us to be upset by Joe's story. I don't want you walking away upset, but I would like you to be troubled by it. I would not want you to be numbed by it, because this is just the way things are. This is how it happens. And of course, if we become aloof and machine-like, that certainly is not good care for our patients, our clients, and the residents that we work with. Somebody did ask me and challenge me, said, Bob, you always speak about it from a point of view of the providers, but I'm mindful of the fact that if we had a good foundation for the providers in terms of the integrity with which we deliver our services, the impact on the person receiving the service can only be positive if we had integrity in what we were doing. I told you about could versus should. I told you about you know that you have moral distress and you feel it in your gut. Another one that I want you to remember is this notion of the language of dual loyalty conflict. And dual loyalty conflict is, first and foremost, we want to be loyal to our patients, to our clients, to our residents. Our personal values say that. We got into healthcare because we wanted to care. Certainly our professional values and all of our colleges speak to our loyalty to the patient. But yet, of course, we have the issue of, those who pay us, those who supervise us, those whom we have to report to, saying we need to get these folks out. And how do we manage that dual loyalty conflict? Some of you may want the dual loyalty conflict definition. A dual loyalty is a clinical role conflict between professional duties to patients and obligations to the interests of a third party, such as an employer, insurer, or the state. Many of you may recall that back on October 16th, I told you this came out of people who did physicians involved in executions, the dual loyalty conflict working group. How can you be loyal to the client, who's this person being executed, when you have to say that they're certified healthy to be put to death, and then do the ultimate harm to somebody? Now, what are some of the sources of moral distress? And you guys can probably tell me better than I can say it to you. But when we perceive or worry that there's a risk to our patients and families, if we send this person home, they're going to have a horrible fall. And this is something I was dealing with yesterday. And this person knows that they could, crack their head open. And we don't want that to happen. Of course, that notion of autonomy comes in here, and that notion of beneficence is challenging that. Treatment of patients as objects when meeting utilization targets. Well, we got an incentive to get them out of the emergency department, or they've been here for 30 days and they should only be here for 2 weeks for that particular illness. Certainly health policy constraints are challenging us and causing moral distress. So far that resonates with people. Also, allocating of ourselves as a limited resource. One of my social work colleagues at the hospital just came back from holiday yesterday. So you know what it's like when you come back from holiday and you're a healthcare professional? Her list was so long, and you're thinking, I've got all these people to see. How can I see them? And these days, if you get in the hospital, you got to be sick. You don't come in for a rest anymore. That was long gone. So everybody on that list is important, and who knows what crisis and challenge is on that list. So allocating ourselves is a source of moral distress. Who is vulnerable? Those who work with, or who is vulnerable to moral distress? Those who work with vulnerable people. I oftentimes think of people who work in the mental health community and how we're challenged to find resources for some of our patients who are dealing with serious mental illness. People in need, and we can't meet their needs. And of course, all of us have had the challenge of working with folks who challenge us. And I know people don't like that language of challenging families, but it's reality. We deal with that. And if you're not happy in your work, then the moral distress becomes even worse. There's a rhetorical question with a rhetorical answer. Who is vulnerable to moral distress? Anyone who cares. If you didn't care, you wouldn't experience moral distress. Now, when you get to the fork in the road, Bambi was asking me for the slides to be shared, and I thought people might not get my sense of humor. But I like this notion of fork in the road here that I borrowed from Philippe Hibert, if some of you may know him. So when we get to the fork in the road, I'm hoping to offer you some strong moral fiber. And by the way, did you notice it says self-regulation guaranteed? And most of our colleges speak to that we're self-regulators. So what can we do? Some recommendations. Bob is getting towards the end of his talk, so that's a good thing. First, take stock of your personal values. It's very important to know, what do you believe? What do you stand for? I had a person ask me a question, Bob, when are you ready to get fired? What will you get fired for? That was a tough question, but an important question for me. Where's my line in the sand, as it were? Also, as a recommendation, align yourself with others who have shared values. how important that is. And I would also say, make sure you know your college professional values. I alluded to it earlier. All of our professional colleges at some level speak to the importance of the person who's in front of us. Yes, there may be pieces in there about stewardship, for sure, but the focus of doing the best we can, doing good for our patients and clients. Also looking for recurring patterns leading to moral distress, because moral distress can be a teacher. It can be a place where we can look for moments of teaching and look for systemic solutions to recurring patterns. So that's why it's lovely to have all of us here together tonight, because maybe there's some recurring patterns that perhaps we could do something about, we could advocate for. Almost finished in terms of, because I know my time is getting close. Teamwork is an antidote for moral distress. Anytime that I have had my challenging cases, how wonderful it is when I can find colleagues, friends that I can go to and say, I've had a crappy day and these things are not going right. But not only unburdening myself, but say, did you do the right thing here? Maybe there's another perspective that we have to look at. And so having a good mentor to help us is so ideal and so beneficial to dealing with moral distress. This other point that I want to make here, extend teamwork to include those across the continuity of care. Sometimes we tend to look at only our silo of where we are. You know, sometimes those of us in the hospitals can be rather myopic. And yet we have wonderful colleagues and friends who are in the community struggling and striving to do the best that they can. And so if we can find ways to link together, and also we have people who are in rehab hospitals and other facilities like that, or complex continuing care. Recognize that we are all partners in care. And it would be wonderful if I could call up somebody in the community and have a good dialogue around what is happening. Because one, that would be good care, and it would help us with the moral distress that we're experiencing. I'm going to come to my conclusion with this slide, and some of you may be familiar with this quote. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Margaret Mead. And so I leave you with this, my thank you, and hopefully we will one day enjoy a real spring, and we'll see the flowers, and we'll see the cherry blossoms. And so that's my piece on moral distress. Thank you for joining us and me this evening.
Anyways, my task this evening is to discuss some of the ethical concerns generated by transitions in care planning. And even as we are not on the edges of life here, talking about end-of-life care or beginning-of-life care, which is the fairly common ground for Catholic bioethics, we are in the realm of the daily realities of acute care. Every patient who enters a hospital has to leave at some point. Every patient. And in discussing ethical concerns around transitions in care planning, I will be focusing my remarks mainly around a patient population who find it difficult to leave the hospital, and these are the alternate level of care, or ALC patients. And in doing this, I will not be examining the plight of patients and their families at an individual level. But instead, what I will be doing is exploring some of the basic assumptions underlying healthcare as it is currently practiced here in Ontario. And these are assumptions that may account for some of the challenges experienced in transitions in care planning, especially for ALC patients. And one note, in my talk this evening, I am going to use the term patient. And in doing this, I am not using it as any sort of diminutive term, but rather in the Latin sense as designating the person who is suffering. A person with dignity, worth, a person to be engaged in care and empowered. So the question is, who is the ALC patient? And in 2009, the Ontario government, after consultation with healthcare providers and advocacy groups, adopted this definition. When a patient is occupying a bed in a hospital and does not require the intensity of resources or services provided in that particular care setting, the patient must be designated alternate level of care at that time by the physician or her or his delegate. The ALC wait period starts at the time of designation and ends at the time of discharge or transfer to a discharge destination, or when the patient's needs or condition changes and the designation of ALC no longer applies. In other words, for a variety of reasons, patients who continue to occupy a bed in a setting no longer appropriate for the care they need, the assumption being that the patient no longer requires such intense care, these patients are to be designated ALC. And of course, in healthcare, the ideal is that patients should be receiving care that is appropriate for their conditions. Here we have the principles of beneficence and non-maleficence at work. In other words, healthcare should be directed to serving the patient, enhancing the well-being of the patient, or at the very least, not harming the patient. In other words, we should be patient-centered in the care that patients are receiving, which in itself should be enough to make the existence of ALC patients problematic. And it would be lovely to think that this is the reason that ministries of health and local health councils and hospital administrators take such an interest in ALC patients. It would be lovely, but to be honest, I think that administrators have other concerns on their minds when it comes to ALC patients, and that would be money. Patients who are no longer requiring the level of care that the setting provides and yet occupying a bed are perceived as consuming costly, inappropriate resources in an already burdened system. They are often called bed blockers. And this is why they are problematic in the eyes of administrators. Of course, the question is, why are they still occupying that bed? And the answer in many cases is that given the care that they do require, even as it is not acute care or perhaps as such intense care, given the care that they do require, there is nowhere else for them to go to receive this care. And so they remain in that bed. And Bob has already discussed some of the moral distress that this can generate. And I believe that Jean will be providing information that will be very helpful and empowering to people and to persons and their families who find themselves having to cope with this difficult situation. What I would like to do as an ethicist is to talk about the broader strokes, about some of the assumptions that we make about healthcare that may, at least in part, be responsible for this situation. In other words, I would like to talk about some of the biases at work in healthcare, in the provision and in the practice of healthcare. And of course, you might say, well, are there really biases at work in healthcare provision and practice? And to quote a recent U.S. vice presidential candidate, you betcha there are, okay? And one way to get to these biases, to uncover them, is to follow the money. Because the fact is, we fund what we value. We give more money to the things that we believe are more important and less money to the things that we believe are less important. How we decide on the importance of something is a story for another day. But at the very least, it is important to know that our funding decisions are not objective decisions. Funding usually goes to those things that we perceive to be important. Now, I remember when I started as a bioethicist many, many, many years ago, there was this rumor that much more money was going into cardiac care rather than, say, obstetrics and prenatal care, because the decision makers in government were, for the most part, middle-aged men, and for them, cardiac care was important. That was just a rumor, of course. But we can still ask, how are our healthcare dollars allocated here in Ontario? And according to an Ontario Ministry of Finance report, in 2010-11, $44.77 billion were spent on health care in Ontario in total. And of that money, doctors and practitioners got 26.6%, prescription drugs were allocated 7.7%, long-term care homes got 7.7%, while community care got 6%. But by far the biggest share of the pie went to hospitals. 34.7%, or $15.53 billion, was spent on hospitals in 2010-11. So if it is the case that we fund the things that we value, it seems pretty clear that we give priority to hospitals, we give priority to acute care in healthcare. We love our hospitals. And why not? They are places where miracles occur, where lives are saved, where illnesses are cured, and these are good things. And from a television perspective, they are places of high drama and sexual tension. But I wonder if, from an administrative standpoint, our love affair with hospitals isn't also tied to our adoption of an industrial model of healthcare. Is this love of acute care tied to our desire to have a healthcare industry? Now, I've made this point in other presentations. I am from the Niagara Peninsula originally, which, given its close proximity to Niagara Falls and the electrical power generated by Niagara Falls, was the site of heavy industry, mostly steel and some chemical plants. The idea behind industry is that you take a raw material and subject it to a variety of processes and transform it into something that it was not before. You transform it into a product that you will sell for profit, which means that you are always aware of your profit margins, the costs of the raw material and the processes, and the market value of your product, or at least what you hope to get for it. Industry is about money. It's about generating money. And it involves setting up administrative structures that exist quite apart from the laborers working with the materials, administrative structures that are there to ensure that costs are contained and profits are generated. Does this sound like a hospital? Maybe. Of course, coming from my background, I have wondered why on earth we would ever want to make healthcare into an industry, particularly in light of the collapse of manufacturing in southern Ontario. As well, I have wondered what exactly healthcare was meant to produce. But for whatever reason, we have chosen to have a healthcare industry, and the beauty of acute care is that it appears to be quantifiable. You can measure it. Hospitals, as part of their administrative structures, have persons in quality assurance who do the metrics. How many patients have come through the doors? How long are the patient stays? What are the outcomes, the readmission rates, wait times, bed occupancy? The goal is efficiency, which is also a value. And the goal is to be effective, making good use of resources, which means assessing, admitting, treating patients, setting them up with good follow-up care so that they are not readmitted, and then sending them on their way as quickly and as seamlessly as possible. It's not a conveyor belt exactly, we're not Lucy and Ethel at the chocolate factory, but at the end of the day, at the end of the month, at the end of the year, the numbers tell you how well you've done. It's simple. But what happens when you get the elderly patient or the young patient who has a chronic condition along with the acute episode that landed her in the hospital in the first place? And the acute condition is successfully treated, but the chronic condition remains. And this means that the patient cannot go home, at least not without help, and maybe cannot go home at all. But they are having problems getting the help, or there isn't a bed available for them anywhere else. There is no place for this patient to go, and the ALC patient becomes the gum in the works. And the cogs start grinding to a halt, and the ER backs up, the ambulances are redirected, patients wait on gurneys in hallways, elective procedures are rescheduled, and the numbers start to look bad because day after day, this patient who no longer needs this care is still in this bed. In an industrialized model of health care where acute care is given priority, the ALC patient is seen as a problem. Imagine making a patient into a problem, but there it is. And so we have this priority that we give to acute care as one bias operative in healthcare. There's another bias closely related to this that I would now like to discuss, and this is the distinction that we make between doing everything and doing nothing. In other words, this is the priority that we give to technological interventions. My first case as a clinical ethicist involved a fellow who had TB. It was drug resistant. He was on a respirator. He was going to die. He was in an isolation unit, in an intensive care unit. He decided that he wanted to be taken off the respirator. And his decision was honored, and he ended up dying in the night. A couple of days later, when I turned up in the intensive care unit as an ethicist, a nurse approached me. She was obviously feeling moral distress, and her fear was this. She was an intensive care unit nurse, and her worry was that she had done nothing for this patient. And I said to her, so the patient was alone when he died? And she said, no, she had been with him. I said, so you were there, but you were just doing your charting? And she said, no, she had held his hand. Tuberculosis involves a great deal of sweating. She had continuously mopped his forehead. Another nurse had come by bringing a radio so that he could listen to country music. The two nurses had been with him as he died. There had been no technological intervention, but can you say that she had done nothing? Here we have another bias that is operative in our healthcare system. Care or treatments or therapies or interventions have value only insofar as they serve the patient, not because of any categories that we may have assigned them. My belief is that if we are to have a healthier healthcare system and one that is patient-centered insofar as the goal is to serve patients by providing the care that they require and valuing the care precisely because it serves the patient, then we must consider the role of palliative care in healthcare. Now, normally, we think of palliative care, we associate it with end-of-life care, and that is hospice palliative care or hospice care. But in fact, palliative care is more than caring for the dying. It is care for persons in their chronic illnesses and or infirmity, and it's aimed at attending to the patient's needs and enhancing the quality of the patient's life in her infirmity or chronic illness. And according to the Way Forward initiative here in Canada, and I quote, the palliative care approach focuses on persons and families and on their quality of life throughout the illness, not just at the end of life. It reinforces the person's autonomy and right to be actively involved in his or her own care and strives to give patients and their families a greater sense of control. It is an approach to care that can enhance quality of life throughout their illness. It is a type of care that is patient-centered. It is holistic in its approach, addressing not only symptom management, but psychosocial and spiritual concerns as well. It recognizes that patients exist within a network of relationships. Families, too, are involved in the care, and they may themselves be the subject of care. And it relies on connection and communication. It is multidisciplinary and respects the skills and compassion that all caregivers bring to the table. Palliative care can take place in a variety of settings, depending on the realistic assessment of the supports needed by this patient at this time. But we know that currently the supports available to patients requiring non-hospice palliative care are limited. From an ethical standpoint, I am suggesting that for our healthcare system truly to serve the needs of patients, and this is why our healthcare system exists after all, we must relinquish the priority that we give to acute care and to technological interventions and get behind a robust program of non-hospice palliative care. The fact of the matter is, as Bob has mentioned, that thanks to modern medicine and affluent lifestyles, our patient profiles have changed. We are living longer. We are accumulating chronic conditions along the way. Palliative care can do a great deal to empower patients and enhance their quality of life. in these circumstances. And these are good things, but there are further benefits. Studies show that good non-hospice palliative care keeps patients out of emergency rooms, leads to shorter hospital stays, and lowers healthcare costs overall. These are also good things. But having made the case for palliative care, for non-hospice palliative care, gosh, this is a mess. I must offer some caveats. The first is that because we are so enamored with acute care, the tendency is to think of palliative care as the thing that isn't acute care, okay? And when we do this, when we think of palliative care as the thing that isn't acute care, then we devalue it, and we also devalue the very real, although not acute care needs of the patients themselves, which has devastating consequences. I lived in Sunnyside here in Toronto before it became the hip capital of the world, if only we'd held on to the house. And I saw what the closing of Lakeshore Psychiatric Hospital did to the patients and to the Parkdale community, as they were sent from an institution to life on their own without the necessary supports. At the same time, in the same way, how can we say to an elderly woman that her husband's acute episode has been treated and he will be sent home and she will get 10 hours a week to help her care for him in his dementia, 10 hours a week, which just leaves her with 158 hours on her own. In other words, to work palliative care must be understood as a vital piece of the process of continuity of care and central to the idea of patient-centered care, and it must be financed that way, which leads us back to that pesky point about funding what we value. And this is going to be a sweeping statement, but it seems to me that the farther away from hands-on patient care that one is, the better one is paid. Who are the lowest paid healthcare workers? PSWs. I understand that over the next 2 years they will get a pay raise of $4 per hour. Okay? But these are the personal support workers, the people whose job it is to spend hands-on time with patients. Are they unskilled? If you use a medical model, you might say that bathing a patient isn't the same thing as performing brain surgery on a patient. But is bathing a patient unimportant? For the patient who does not need brain surgery, but who does need a bath from someone who is patient, skilled, kind, who talks to him and treats him as a person with dignity and respect and love, that bath, that point of healing contact is very important indeed. And I believe that it behooves us to recognize this and to value it. This is patient-centered care. Now, I realize that I have been speaking in broad strokes about things like biases in healthcare, and fortunately this is a panel discussion, so you're likely to get some very relevant information in our next talk. But let me finish in broad strokes. Just how important is the palliative care approach, this hands-on, holistic encounter that has the potential to be mutually beneficial and mutually healing for patient and caregiver? In his exhortation, Evangelii Gaudium, the joy of the gospel, Pope Francis wrote about the importance of open, authentic encounters or communion between persons. And I found this passage highly applicable to healthcare. He wrote, "The Christian ideal will always be a summons to overcome suspicion, habitual mistrust, fear of losing our privacy, all the defensive attitudes which today's world imposes upon us. Many try to escape from others and take refuge in the comfort of their privacy or in a small circle of close friends, renouncing the realism of the social aspect of the gospel. For just as some people want a purely spiritual Christ without flesh and without the cross, they also want their interpersonal relationships provided by sophisticated equipment, by screens and systems, which can be turned on and off on command. Meanwhile, the gospel tells us constantly to run the risk of a face-to-face encounter with others, with their physical presence, which challenges us, with their pain and their pleas, with their joy, which infects us in our close and continuous interaction. We are, according to Pope Francis, summoned to, and I quote, a revolution of tenderness. A revolution of tenderness. Imagine what healthcare would be like if this were the driving force. Imagine the possibilities for transitions in care planning as well. Thank you.
So I'm not going to talk too much about ethics, except as sort of I interpret them. I'm not an ethicist. I don't talk about beneficence and maleficence and all of those things. Those are two big words for me. But I am going to talk about what the law is. And my opinion is that the law is the base of ethics. And if it's not legal, it's not ethical. So if you're dealing with the law and you think it's wrong, you're going to have to change it. I mean, that's the basic. And, we certainly do have laws from time to time that perhaps we don't agree with and we do want change. It's not, we don't ignore the law because that is what we think is good for our institution. I'm very interested, Phoebe, in your case study because it's not reflective of what I see. Because in your case study, it would appear that the hospital was very upset at what was happening and the CCAC was the problem. And in general, I would say it's a little bit more the hospital than the CCAC, and I'm sure you see. I know it's just a case study.
I actually want to just make sure that
Sure.
it was both sides.
Okay.
Very careful because practicing at CCAC also.
Okay.
I discussed with both groups equally, so
Good.
Sorry.
Good. Because the general thing is that it can be both. It can, we have good and bad on either side. But I would say that in general, the pressure comes more from the hospital because it is obviously their bottom line. And I agree, it's the dollars that are running this. It's their bottom line that is driving this. I think part of the other problem is that we do have a Ministry of Health that says these are the laws, and I'm going to talk about what Deb Matthews has to say on this. And on the other hand, she's paying for performance to get the patients out. So, she's sort of sucking and blowing, right? She's saying one side one thing and one side something else. So, that's some of the things that we see. The legislation with respect to sort of ALC, there's a lot of things that, if you're dealing with this area, you need to know. So you need to know the Public Hospitals Act, you need to know Long-Term Care Homes Act, Healthcare Consent Act, Substitute Decisions Act, Regulated Tenancies Act, the Retirement Homes Act, the Health Insurance Act, Public Health Information Protection Act. Those are just but a few of the things you're probably going to have to think about. With respect to some resources, I'm just going to suggest that you go to the ACE website. It's acelaw.ca. We have a lot of stuff on that website. I've written about, I think it's about 14 pages right now. It's a paper on discharge from hospital to long-term care. Covers most of the things. There's also a tips and traps, which is a shorter version. Really talking about what the law is from our perspective, analyzing it, and really doing it from that patient perspective. There's also a provincial ALC definition out there. We deal a lot with co-payment issues, so there's also something called the Hospital Complex Continuing Care co-payment paper, which is available from the ministry, although I appear to be the only person on the earth who knows it exists. But it talks about when can you charge and when you can't charge, because a lot of the time we see ALC equals you must pay, and that is absolutely not correct. ALC does not mean you have to pay. A small portion of ALC patients can be charged in hospital. And it's not a requirement, by the way. You don't have to charge. You can. There's also 3 memos from the Ministry of Health. Most hospitals are very familiar, and the Ontario Hospitals Association talks about it. There's one by Rachel Campus on May 23rd, 2012. All these are on our website as well. That talks about if a patient refuses a bed off of their list, you can charge them $1,500. The hospital really likes that memo. They don't publicize so much the first memo in the series of 3, which said that you can't threaten people with $1,500 charges if you pick off the short list, if you don't take an idle bed, things like that, or something like that, follow the hospital policy, then we're going to charge you $1,500. Ministry said that was illegal. And then the Homefirst philosophy. Homefirst, and I'll talk about it. Homefirst is a philosophy. It is not a program. There are not specific dollars attached to a specific program. There isn't regulations around a program. It is a philosophy. So again, it can be offered. It cannot be mandated. You cannot force someone to go home on Homefirst. But I think that's very important. Issues around alternative level of care are the they are the highest number of calls that we get at ACE. If you're not familiar with our office, we have 5 lawyers, we have 2 intake workers. Most of you probably know Judith well as well, who's our director. We have some litigation lawyers, 3 litigation lawyers, and I'm the institutional advocate. So I get most of those calls around these ALC calls. We dealt in our office with approximately 300 calls on that issue alone last year, and that's a lot for me. So I'm trying to solve this so that I don't have as much work. We get a lot of calls around the Wait at Home or Homefirst programs. We got a lot of calls about people being told that they have to take care of their spouse at home, refusing to allow applications to be made in hospital, threats of charges, requiring people to go to a retirement home. A lot of the time when they're talking Homefirst, they say, Homefirst is that you have to go to a retirement home. Well, that's not actually their home if they didn't come from there. So then, in my opinion, it's not even a Homefirst issue. There's a lot of calls out there. It's the tip of the iceberg. We really know that. If I was getting every call, I would have changed the system already, because everybody would be disagreeing and it would be, quite easy to change. But we know that only a very small proportion of people come to our office. We try to get the information out as broadly as we can. But we know that the hospitals and the CCACs are pushing these programs, pushing these kinds of rules, that the hospital policies, on people who just go ahead and do it because they're in distress. They don't know what the rules are. They don't know that they can challenge it. They do believe that nurses and doctors and social workers, etc., only have their best interests at heart. So when a social worker comes and says that you're not allowed to apply to long-term care from hospital, you must return home, they assume that is correct, because frankly, it's probably illegal for you to say that, and it is probably a breach of your college rules to say that, and a whole bunch of other things. So they assume that what you're telling them is true. So I think that a lot of people just go along with it. They're also in a difficult position in that you control the process, and that if people who are in hospital or CCACs are telling them things, if they don't do what they're said, well, maybe they'll never get to long-term care. Maybe if the parent or the husband or whoever has to come back to hospital, they're not going to be treated well. And I hear that a lot. If I challenge this, are they going to treat my parent or spouse or what have you badly? I do want to mention very, very briefly charges. So under the under the Health Insurance Act, you can charge for ALC co-payments. But only in a very small number of cases. You have to be more or less permanently resident in a hospital, and it has to be a certain kind of a hospital. So some hospitals are not allowed to charge at all. But again, you have to be more or less permanently resident in a hospital or other health facility. So if you're waiting to go to long-term care, you're going from a one place health facility to another where you're going to be permanently resident, you can charge. If you are going home to wait, you cannot be charged. If you're going to a retirement home, you cannot be charged. If you are in rehab, and I don't care if you call it slow stream, upstream, downstream, I don't care what you call it. If it's rehab, you cannot charge. And why this is really important is we get a lot of calls from people who are being charged, and they're very upset. They don't understand why they're having to pay for health care. They don't understand what's going on, and it may be a burden on them. And so we have to make it very clear that certain patients can't be charged, and if you're a mental health patient, you can never be charged. So if you came to the hospital on a Form 1, Even if they make you LC, they can't charge you. And also that there's reductions available. And again, this is both in the hospital and the long-term care sector. Usually the hospital, everybody knows that if you're low income, you know, on OAS, GIS, you get a reduction. Not well known is that if you have a spouse under the age of 65, you get a much higher reduction. Spouse doesn't have to sell the home. She doesn't have to do the cash out the RSP. She doesn't have to do a lot of things. And again, this is a time of people being in a great amount of distress, and sort of these fee issues can be very, very problematic. So what we run into is a lot of hospitals telling people a lot of things that are not correct. They are telling people that that they, you know, can't apply to long-term care. There's a lot of pressure put on people. You know, we heard about hearing about, you know, maybe we should be looking at doing the discharge process earlier. The earliest I've ever seen was in the emergency room before the person was admitted. The spouse was handed a piece of paper that basically said that she was obligated to take her husband home when the doctor had said so. Now, this is prior to her her husband being admitted. Do you think she signed it? Absolutely. She thinks if she doesn't sign that piece of paper, he's not coming into the hospital. And very often I ask people, why did you sign a document? And they said, well, if I don't sign, he wouldn't get the care. And I said, well, you know, we have universal access, we have health care. They actually cannot penalize you for not signing certain kinds of documents. You cannot refuse to provide a person with health care just because they don't sign some sort of a policy agreement with your hospital. So as long as you've got that OHIP card, you get that care if you're entitled to it. So, you know, but a lot of people, they don't know that. They're not sophisticated, and they're very fearful. There's a huge amount of fear out there. So we really have to make sure that we're providing information that's correct. What's my time frame here? Oh, okay. All right, I'm going to 7:30, right? Okay. So, yeah, you moved that, I said. I thought maybe you just wanted me to talk forever. 7:25 if I want. There's not going to be any questions. So, long-term care, when it comes to long-term care, the application process is really done by the placement coordinator. So the CCAC is the entity that has authority to do applications. It is not the hospital. And that has been slowly over time, and people who've been in the sector for a long time probably remember a time when they did almost the whole application and then just sent it off. That anything to do with the application process has been taken away from almost anybody except for the CCAC. And that's because of the manipulation through the hospitals, manipulation, frankly, through the long-term care homes. We had a lot of long-term care homes when they did their own bed offers. They were manipulating, cherry-picking off the lists, doing all sorts of things. So they had to take it back to an entity, the CCAC, who is supposed to be working for the client. They're not supposed to be worried about hospital budgets and all of that sort of thing. We know it's a fallacy, but that is the theory. Of course, the CCAC people are embedded in hospitals, so their office is downstairs. They're not actually at the CCAC office. So if things aren't going well, I'm quite sure that the hospital administrators sort of knocking on their door saying, what are you doing? You're doing too many applications. And I know that they have a lot of problems. And there is burnout. And I know there's a huge burnout in discharge planners. I wouldn't want to be a discharge planner. You could not pay me. And for anybody that there's a discharge planner, my condolences. I hope they are paying you a lot. Because it is very difficult. And there are issues around your own licenses. Most discharge planners are nurses, sometimes social workers. And if you are providing misinformation to people, which they are, I think, you know, your license is on the line, and we are starting to make more and more complaints to colleges to say that they are not complying with the law. So it's up to the CCAC to do things like determine eligibility, assist people to apply, to choose homes if the person requests. There's no mandate. The CCAC does all the application, except for the doctor or the nurse practitioner will fill out a medical form. But pretty much all of it is done through the CCAC. They have to ensure that the choices that are being made are being done through informed consent, that they're voluntary. So being told that you must choose 5 and that 3 of those must be off the list, and here is the list of the short homes that you must choose, is not legal, because it's not true. You can't do that. If a CCAC accepts homes on that basis, they're not valid consents, and you can challenge that. You cannot require a person to go to a long-term care home if they don't consent. So we hear a lot of people, happens all the time, hospital says, well, I got the idle bed list today and there's a female bed at Shady Acres down the road, and so, you know, if you don't go to Shady Acres, we're going to charge you $1,500 a day. And they say, well, I didn't apply to Shady Acres. It don't matter. You're eligible. Well, actually, you're not. There's no eligibility until you apply. There's no eligibility until you consent to the application that goes through. So, in fact, we don't even know that they're eligible for that home because they've never applied, and frankly, they don't want to. You can't make a person choose 5 homes. Somebody today asked me, one of my colleagues yesterday, actually, because I was out with Frank. Frank and I have done this yesterday, and somebody called me. One of my colleagues said, is it true that you can't be crisis if you only have 2 facilities on your waiting list? I said, no. So what's the eligibility? It's the person requires a certain level of care, and it's urgent and all of that. It says, there's nothing there that says, and you must have X number on the list. Of course, it's very helpful if you have more, but no, the CCAC cannot say that you have to have 5, 10, 15, whatever on the list. So you got to go back to the CCAC and tell them that that's incorrect. You can choose 1 home. That's an application. You only have to have 1 home on your list. You do not have to have 5. I recommend to people in this day and age, in most places in Ontario, you want to choose as many homes as you can, usually 5, but you have to be homes that you're going to be comfortable with. You never put a home on a list that you haven't gone to see or had someone see on your behalf. Because if that home comes up and if you've chosen it, and it was, and sometimes people will do it because someone told them to choose the home and they choose it, and then the bed comes up and they go and see it and they don't like it, well, you're in trouble, because that's when the hospital could start charging you $1,500. Or if you're in the community, that's when the hospital, the CCAC will take you right off the list and make you ineligible, and you'll have to reapply in several months. You can invite people to do things. You can say, we think it's a really good idea, and this is why. And part of the thing that I do in my job is really what the discharge planner and the CCAC should be doing, is telling the person, really, you've chosen Baycrest and Kensington Gardens, and you've chosen Providence, and yes, they are lovely facilities and have really good reputations, but they're a 5-year waiting list, and your mother's 94, and she's sitting in an acute care bed in a hospital. Probably not a good idea. And as a substitute, substitutes also have rules they have to comply with. They have to look at what the competent wish of the person is. They have to look at what's in their best interest. And if they're not doing that, they're not doing their job, and that can be challenged. So is a 5-year waiting list really appropriate for someone waiting in hospital? Probably not. It is really sad when I tell people, you have these choices, and they choose, and they say, I'm going to just wait for that 1 home, and I don't care how long it takes. My mother deserves the best, and then mom dies of C. diff in the hospital. So I'm always telling people about how difficult it is in hospital. I've had 4 back surgeries. My roommate is always a 90-year-old who's had a stroke. And since I was 15, I've spent my time in the hospital advocating for my roommate. I know how bad it is out there for those people. I know how bad it is for me in a hospital, frankly. You don't want to spend a minute more in a hospital than you really have to. As a patient. I mean, as an employee, you might want to, but as a patient. But there are the occasional people that do, and that's generally the younger person, the very competent person, who says, you know what, I know what it's like out there, and I don't want to go to Leisure World St. George, which has a bed, because it's a really kind of yucky-like place, and I didn't like it. It's good for some people, it's not good for them. You can't make them go there. They said, I've seen Kensington, that's the only place, and I'm 49 and I'm willing to wait. Not much a hospital can do. You can provide them with lots of information, lots of choices, but at the end of the day, there's not much you can do. You can always choose. You can provide people with alternatives. There's a Homefirst philosophy. You can go home. This is what you're entitled, this is, what we might be able to do for you at the home. One of the big problems with the Homefirst, so going home and waiting in the community, is that very often what I hear is, okay, we're not going to let you apply in hospital, which makes no sense to me anyway, because you always want to get this application started as soon as possible so you can be on the list. But that doesn't stop them from going home, and lots of people do go home, even though they've already started the application. But, if you want to go home, CCAC will come home, you go home, CCAC come, they'll decide, how much care that you're going to get and everything after you go home, and I say, My clients, I tell them, you don't leave the hospital until you have something in writing from the CCAC to say what the services are, like what are the parameters, what happens if they don't show up. This is a big thing in retirement homes, because sometimes the retirement home will provide the service and then charge you. And I'll tell the CCAC, we're requiring you, if we go on this and your service provider doesn't show up, you're going to pay the retirement home, not the client. And that's the sort of thing that we deal with a lot, trying to sort of advise people. Nobody can make up these sort of arbitrary rules around, policies in the hospital. The law is the law. So if your policy says, every person in hospital must choose 5 homes, that's illegal. It's contrary to the law. You can't have it. You can't do through the back door what you can't do through the front door. So we're seeing a lot of hospitals saying, well, in order to apply to our rehab program, you must have an application from the CCAC. If you think you're going to be maybe going to long-term care, you must have an application that has at least 5 homes on that list, or, and 3 of them have to be shortlisted. No, again, rehab or chronic care, if you require it, you require it. It's part of the healthcare system. You can't have these arbitrary parts of the application. And the same with Homefirst. You can't say we're going to put you on Homefirst, but only if you have a certain number of choices. So that's a little bit about what I do. I know my time is getting short, so I'm going to stop talking, and I'm sure there may be 1 or 2 questions. Thank you.